quick introduction for Gay Corbett here. Delightful to have you here, all the way from Ballarat in Victoria, in sunny Australia.
It is at the moment.
Yeah, coming in sunny at the moment. And she's a prostate cancer specialist, nursing service person.
Yes, that's right.
And terrific to have you here. I'm really looking forward to the presentation.
Great. Thank you very much, John. So thank you very much for having me here to talk to you about my passion, which is prostate cancer nursing and erectile dysfunction. So I'm talking to you about a program that I've started in Ballarat, which is called When Prostate Cancer Joins You in the Bedroom. So hopefully you'll enjoy this and get some insights into what I do, and certainly happy for anyone ever to contact me with any ideas, come and see what I do. It would be fabulous. Firstly, I'd like to say I've been watching Handmaid's Tale, so I'm very excited to be on this side of the border in Canada and safe, and a long way away from Serena. And if any of you haven't watched Handmaid's Tale, well, Serena's not very nice, and certainly America's not the place to be. Canada's the safe place, so happy to be here. Okay, so I am working in collaboration with Prostate Cancer Foundation of Australia, and that is a peak national body for prostate cancer in Australia. And its role is to reduce the impact of prostate cancer on Australian men and families. It promotes and funds research, innovative research nationally and internationally. It actually implements awareness and advocacy campaigns for the community, education programs for the community, health professionals and the government, and its jewel, which I think, the jewel in its crown is the establishment of the prostate cancer specialist nurses, of which I am one. And so this is a picture of some of the prostate cancer nurses. But initially, this program was established with a grant from Movember to Prostate Cancer Foundation of Australia in 2012, and that funded initially 12 prostate cancer nurses throughout Australia. Organisations had to apply to PCFA and put a business case to them to show why they needed to have a prostate cancer nurse, and so 12 were positioned around Australia. Since then, since the 3 years initial funding, the federal government took on the funding of prostate cancer nurses and established another 12 prostate cancer nurses, which I was in that group. And there are 48 prostate cancer nurses. Probably 40 of those are funded by the government and 8 by local communities who were a little bit upset that they didn't get a position. And so with local fundraising, they've been able to support prostate cancer nurses in their hospitals. Probably Victoria has about 15 prostate cancer nurses. At the moment, there is only one in the Northern Territory. They hope to be expanding that and moving from 48 prostate cancer nurses to 150, which would match what the breast cancer nurses are in Australia. So that's our big challenge in the next 3 to 5 years. So the money is given to Prostate Cancer Foundation, and I'm hosted at a hospital called Ballarat Health Services, and my role is a regional role, so not just covering that hospital but covering the whole region. Some of the roles are just for the hospital, but we work within a framework for practice and professional development, and that's based on basically cancer practice models, best practice models, and so it's been adapted for us to work within. So we have a fairly strict framework that we work within. So this is Australia, and down the bottom you can see Ballarat, where I'm actually working from, Ballarat Health Services, and the Grampians region is the darker green, and that's the area that I cover. So it goes right across to the South Australian border, and Ballarat's about an hour from Melbourne, and I'm certainly right down in the closest to Melbourne, but I have to cover a long way, which is about 4 to 5 hours away from Ballarat. So I do have to do some travel sometimes. Ballarat Health Services is the major hospital in that region, so most people will come for treatment there. And this is Ballarat Hospital. It's had many add-ons. The top left picture is originally the original hospital when it was built, and behind that is our cancer services, and another couple of angles. We are about to upgrade again, so there'll be more architecture designs and a different architecture, but it's all a work in progress there at Ballarat. So here is the region. It's 48,000 kilometres. It's 20% of the state. The population is about 250,000, and of that there are 117,000 males, and 43% of those are over 45 years of age. So this is the demographics that I'm working with. For our region, we probably have the highest prostate cancer mortality rate in the state, which comes in at 18% compared to the average of 12.5. 25% of newly diagnosed patients in the Grampians region have advanced disease of prostate cancer, which is a Gleason score between 8 and 10. There hasn't been an extensive study done on why this is the case. There is some speculation, and some of that is that it's a very rural and area with a lot of farmers, a lot of transient GPs coming through the area, so people haven't established great rapport with their GP, and so it's not the going out to the local football game or in the community where the GP says, gee, John, I haven't seen you for 12 months, why don't you come in and get checked out? It's a lot of doctors going there for 6-month placement, so there isn't a great development of rapport. And also that men are very busy with their work, with their either wheat farming or sheep farming, and so they don't often see the time to go. And there is some research saying that the men in this region see themselves as very stoic still, and that they're not presenting to the doctors until things are quite advanced. I would probably have about 180 men diagnosed annually with prostate cancer, and as I said, 25% of those are advanced disease. This is me, and this is the website that is at Ballarat Health Services. We have a website for the Cancer Centre, which is Ballarat Regional Integrated Cancer Centre, or BRIC for short, and people can link on here to all the services that we have and see what we can do. I look after both public and private patients in Ballarat, and however I'm situated at the public hospital. Across the road is St John of God Hospital, which is a private hospital, but I'm there to see both public and private. So I do a lot within my role, but today I'm focusing on erectile dysfunction and sexual wellbeing. So in our region, we do the services or these treatments that we provide are radical prostatectomy. We don't have a robot yet to do robotic surgery. We do radiation, which is external beam radiation, hormone therapy or ADT, and chemotherapy. So all of these impact on sexual function. We don't do brachytherapy. We have moved away from brachytherapy in Australia, and certainly in our region, we're really focused on active surveillance. And so that's monitoring the men every 3 months for their PSA or their blood level of their prostate-specific antigen. And we would do a biopsy every 12 months for the first 2 years, and we're lucky enough that we have a transperineal biopsy machine, so we're actually putting men under anaesthetic to have the biopsy, and it takes 20 cores instead of the trust biopsy, which is common practice over here, and that takes 12 cores. We're finding that men are more keen to come back for their biopsy because they're not awake and having the cores taken through the rectum. This is done in the perineal space, so there is reduction in infection, and it's certainly a much more pleasurable experience. So even men are more adherent to active surveillance because it's not painful. So what does prostate cancer do? Any of the treatments can cause a variety of things, which include a dry ejaculation, penile shrinkage, which is never pleasant for any male, erectile dysfunction, climacturia, which is loss of urine at climax, painful orgasms, loss of libido or desire, and coupled with fatigue. And fatigue can come from cancer fatigue and also from the treatments that the men are undergoing. So there was a summit done in Victoria in 2017, and it stated that sexual dysfunction is still reported as a concern for men 2 years post their prostatectomy or radiation treatment. And 47% of men were identifying sexual health issues as an unmet need. And it also indicated that men with prostate cancer were reluctant to access psychosocial support. They saw loss of erectile dysfunction as a very difficult survivorship issue, which resulted in an impact on their quality of life and also their relationships. So with all of this going on, the men were in the region started to ask me for solutions to erectile dysfunction within my role. And looking back through my data, 25% of all my consults were around sexual wellbeing, sexual dysfunction or management of sexual dysfunction. And so I thought, gee, I better get a little bit more experience in my management of erectile dysfunction or sexual wellbeing, because at 4 months after a radical prostatectomy, men, once they had got their continence issues sorted out, were coming and saying, you know, things have gone back to normal for me except for this erectile dysfunction and I don't feel right. Something's wrong, something's missing. And it was becoming more and more obvious. And the medical professionals were certainly, and they will admit, not equipped to deal with this. They're busy, limited appointment time, especially the urologists. They've got 20 minutes to talk with someone. They lacked experience, and a couple of them were saying that in their training, they got to watch a film of a couple having sex, and that was basically their education for management of sexual issues. And they felt poorly equipped themselves. They were more than happy to help me upskill. And there wasn't a service that we don't, in our region, we don't have a sexual therapist or a psychologist that was really taking on this area. So it fell back on me, which was fine. So I took this up, and I was lucky that I saw Deb McLeod from over here in Canada come and speak at a conference in Australia, and she talked about a course through, I say De Souza, I'm not sure how you pronounce it here, De Souza Institute, and it was an online course for sexual health and cancer for male and females, and it was offered at 349 Canadian dollars. So I applied to De Souza and was lucky enough to get into the course. However, I had to get up at 4 o'clock in the morning to do it, so that wasn't that pleasurable. And, you know, during some of the course we would have to, in one session we had to look at a couple having sex, and there I was in the hospital at 4 o'clock in the morning with my headphones on in my office watching a couple have sex, and security come past and saw what was on the screen and saw me and said, "Are you right, Kay?" And I said, "It's actually work. It is work that I'm doing." And they went, "Oh, okay, yeah, right." But it was, and look, it was fabulous for me because there was online discussion and I could talk with sexual therapists from here and oncology nurses, and it involved some reflective pieces, and I think it was really beneficial for me to challenge some of my biases, to hear what other people are saying, and to really start developing some ideas around sexuality and cancer. And it was with this group that I workshopped the idea of this 90-minute session that I was doing, and we came up with the name "When Cancer Joins You in the Bedroom," or "Prostate Cancer Joins You in the Bedroom." So it was fabulous, and I recommend anyone that's in Canada to certainly have a look at this website, because there are certainly lots of different courses that are offered, and I got a lot of benefits. Some Australian prostate cancer nurses are now enrolled and doing this course as well. So this is the "When Cancer Joins You in the Bedroom," or "Prostate Cancer Joins You in the Bedroom," and it's advertised through our wellness centre in the cancer centre at the hospital. They're 90-minute sessions, and referrals can come self-referral or from multidisciplinary team, recommending that men and their partners come along to this. I really encourage partners to attend because I see prostate cancer and sexual dysfunction or sexual wellbeing as a couple's concern, and certainly men who aren't in relationships come as well, and I encourage that. I would find that it's generally, or the majority have been heterosexual couples, and gay couples tend to want to see me on their own in another clinic I call the SWAT clinic, which is Sexual Wellness After Treatment, and that's more of an individual meeting with me. I think because of the demographics of Ballarat as well, some men feel more uncomfortable to go and talk about their sexual needs, gay sexual needs, in a group setting. I usually cap the classes at 14 so that we can keep it fairly intimate, and I did present this to a support group in Horsham, which is about 3 hours away from Ballarat, and they said there were going to be 18 people there, but actually when I got there were 40 people at the session, and I continued with the session, but it's not as intimate and it's difficult to create or generate discussion when it's such a big group. So I try and cap it at 14, maybe 16. It's an informal setting, and I usually do it just after lunch, and we usually sit round in a circle in a very non-clinical looking room. So, and I would offer this probably about every 4 to 6 weeks in Ballarat. So this is, I'll just run you through basically what the program looks like, and I'm not putting all the slides in, but you'll get the majority of what it's like. So I just put this slide up for when they're walking in, and they'll come in and introduce themselves and sit down, and I would know all of the men that are coming, sometimes not their partners, but we just introduce each other and have our name bands on, first names, just so people can talk to one another or comment on what someone else has said. And then the first slide that I'll put up is just about sexuality. So this will often, I'll ask people in the group what they think sexuality means, what it means to them, and then we'll look at this, the WHO definition of sexuality, and we'll often discuss, what that means for people. It depends on which group, the group dynamic. Sometimes I'll have a group that's really very engaging and will share a lot, and other times I'll do a lot of the talking, and people are just happy to take on board the information, and they'll often come back and see me in the SWAT clinic, which is the individual clinic, or I've had people that have come back a second time when they're more prepared, I suppose, to take this information on again. They've heard it once and they want to come back again, and they're more ready to take on some of the ideas or think about these ideas again. So it's not limited to couples coming or men coming just once. It's open to come again. Then I look at the Cancer Council of Australia's definition of intimacy and talk about it's about being loved and mutual care and concern, and showing the value of another person and feeling valued in return, and about talking and listening. So trying to make them understand or discuss there is a difference between sexuality and intimacy, because often people will couple that together. I would find that often I'm the first person people have spoken to about sex outside their mates at the pub or their partner. So to actually start generating and separating out thoughts and ideas about sexuality and intimacy, men will say, this is the first time I've actually thought about it, and gee, Gay, I wish I'd met you at 18 because I'd understand a lot more now about sex than I do. And I range, the men that I would see range from, the youngest I have is a 44-year-old man with prostate cancer, and at the moment the oldest I'd have is probably 92. So we talk about this, and then I go on and we outline what cancer can actually do to men or to women as well, just what cancer can do to an individual. So it can disrupt the desire and arousal phase. I do put up the slide about desire and arousal before I put this up, but I thought I wouldn't do that today. So we talk about how that's different. I often say men are instant gas stove, they're very ready for sex, and women are the slow combustion wood stove, and you need to stoke the fire. Men, you need to stoke it, and they're not as easily aroused as men are. And they, some of them say, I've never really thought about that either. There is erectile dysfunction, lack of libido, and certainly see a lot of that with hormone therapy. There is a reduction in the size of the penis, and that comes from the operation, but it also comes from hormone therapy. There is fatigue. There are dry ejaculations if there is a radical prostatectomy done. And there's a negative effect on body image and sexual perception as well. So these are some of the things that cancer challenges men on. We talk about the benefits of sexuality with cancer, how it can lessen emotional distress, improve that psychosocial adjustment in the face of cancer. It relieves stress, it can be life-affirming, and it nourishes relationships. And it's interesting that when I talk to men initially when they're going for a radical prostatectomy, they will say, oh, look, you know, sex isn't part of our life anymore, and we don't engage in sex. And I often say sometimes it's not actually about you having sex with your partner, but it's about how you perceive yourself and how you identify, and until it's taken away from you, you may not know what impact it's had on you. And I find a lot of men will actually come back later and say, I thought I had this really well contained and didn't think that it would be a concern to me, but in actual fact it's been quite challenging, quite destabilising, and often they will report that they've experienced depression as a result of it. But not all men, but I certainly bring this discussion up before they have surgery now, because it seemed to be that men were worrying about it at 6 to 12 months afterwards, and no one had mentioned this to them in terms of medical staff. So they were thinking they weren't normal, and they were having an odd feeling rather than what I see as a very common and normal feeling after erectile function is taken away from them. So we go through the benefits of sexuality with cancer, and often there's some engagement and discussion from the group about this. I put up the picture of a prostate as well, because I have had one man who had advanced prostate cancer, and he had a nephrostomy tube put in his kidney, and he thought that his prostate was up in his back. So, it astounds me how sometimes people can get through a lot of consults and either, I'm sure they're told, but just not take on board what's happening to them. So this gives a picture of the prostate, and I show where the nerves are over the prostate and how it's not just as easy. There's not a signpost on them saying here's the neurovascular nerves and we can just protect them if we're doing a radical prostatectomy. They almost have to peel them off the prostate. So any disruption to nerves can cause some neuropraxis. It sort of shocks the nerves, and so I explain that they may not be cut, but they will be damaged by being touched, and that it's actually takes some time for the nerves to regenerate, if they ever do, or the function to come back. So I think sometimes this slide has quite an impact on the men to actually understand what's gone on. In some men report to me that they feel it's their fault. And really, this sort of challenges that for them, in that there's actually a real reason why the erectile dysfunction occurs. It's actually damage to the nerves, and as much as they want to improve things, it's not about the psychological thing. It's actually the biological damage and destruction to the nerves, or at the time of surgery, and also when radiation happens, that it can cause damage to the nerves there. So for me and for the men, this seems to be a really important slide to have up there. There was a study done by Jane Usher and some others in 2012, and in that she reported that sex is still seen often by society as penetrative intercourse. So when we talk about sex, I had sex with someone, people automatically imagine penetrative intercourse. We do talk about phone sex, oral sex, mutual masturbation. However, I still think I agree with what I see from Jane Usher, that often people see sex as penetrative sexual intercourse. So what I'm trying to do is in the group is discuss other options and reframing sex in a different way. So challenging or moving the goalposts, or challenging people's thinking about how you can have a pleasurable sexual relationship without penetrative intercourse. So we talk about the treatments that are offered, or I talk about the treatments that are offered, and it really is dependent on the objective of the couple. It could be about re-establishing intimacy. What I often find is when the erectile function occurs, men don't want to start sex because they feel like they're false advertising, that they're not going to be able to produce an erect penis. And then women worry, in the heterosexual relationship, women worry that they're putting pressure on their partner, so they don't want to initiate sex. So what happens is there isn't the sexual contact, and before really the operation, often a passionate kiss would end up leading to sex, and so all of a sudden people report they're not doing that, they're not touching, there's no love tap on the bottom or anything. So it reduces that intimacy and that connection. So sometimes people are coming to re-establish that. It might be about getting an orgasm, and often men are quite surprised to find, and certainly some of the medical doctors were surprised to find that men can get an orgasm without an erection. And so I often encourage them to go home and try that, and they come back going, yes, I never knew that this would happen. It could be about masturbation. It could be about body image. And I have had some men say, I just need to know that I can have an erection. And if they get an erection, they say that I just needed to know I could. And I only wanted the treatment, intracavernosal injection once or twice just to know that I could have an erection again, and I'm quite happy with that. Or some couples are looking for penetrative sex again. So depending on the objective, there are different treatments for that. So we define and talk about sex not just as penetration, and look at other sexual practices of masturbation, mutual genital touching, oral sex. I haven't at this stage had anyone ask me to explain to them what oral sex is, and I'm grateful for that, actually. So we talk about embracing intimacy, cuddling, kissing, non-genital touching, maybe use of sexual and medical aids, and just the importance of communication, of actually talking to one another and discussing what you might want. And for some men, their partners don't want sex or don't want to have any erectile function. They're quite happy to have a relationship with the intimacy and the masturbation, and they're happy with that. So the men are very eagerly seeking erections, and the women are reporting that they don't actually want that. And so sometimes that takes a bit of pressure off. When I was last week, I was with Lauren Walker and John Robinson at Calgary. They're psychologists there, and they actually have in their program, they actually get the couples to talk together and develop a sort of plan about what they want, and separately, and then compare those together and then talk about what they could achieve. I think that's something that I'll be taking back to my practice in Ballarat. I think that's a great idea, to be seeing on what page both couples are and where they can actually meet together. So, we then talk about communication and how it's sometimes these slides just go up and speak for themselves. Sometimes I speak to the slide depending on the discussion, and sometimes the group will speak to the slide as well. So I certainly think communication is the key to progression with all of this treatment. We talk about that there may be some pain, and with some men having treatment for erectile dysfunction, certainly the intracavernosal injections can create a lot of pain after orgasm, or even the injection itself. I notice here in Canada you use prostaglandins. We use our Prostadil in our injections, which causes a lot of pain. If that is the case, we move on to another compound drug called Trimix, but sometimes men will be reporting that they have pain. However, they're getting an erection, but they're too embarrassed to tell their partner they've got pain because they're getting an erection. I encourage them to talk about this and highlight that this could possibly be a side effect of the injections that they get, and we can certainly use something else. But there could be, often a lot of partners have both got cancer, in the situation. So it's about accommodating that pain for the partner as well, and working together to see what's the best position, what time of day, all of those things. We talk about sitting there and listening and giving your partner full attention and listening to what they actually want, and then you being able to have the opportunity to say what you want. Sharing their fears. Some say that it's very difficult to have contact, eyeballing each other. So I say sometimes it's a great idea to go and sit on the back step and look out at the back fence and talk at the back fence, or lay in the bed and talk to the ceiling and say, this is how I'm feeling, and this is what I want from you, or, I feel like I'm letting you down, or whatever it is, or gee, wasn't that moment together where we were just touching magnificent, and I thought, when you touched my left earlobe, it was completely orgasmic, and so to be able to share that sometimes, it's difficult, and we're even finding with our social workers at work, they're finding if they sit beside someone and not look directly at them, that they're actually getting a lot more disclosure from their patients. So I also discuss, and it's written in a lot of places, that actually if you make time, quarantine time to be together, it shows that the relationship is important to you. So planning a date night, planning some time to watch, if it's football, the AFL in Australia, if it's to sit there and watch that, maybe it's to go shopping and cook a meal together, it could be hiking, it could be something, but actually quarantining time together is important. And we certainly, all of us, get very busy with life, and if something's not working, it's often very easy to avoid it. But to spend time together and develop that intimacy seems to be of great benefit to couples. So then we go on and talk about treatments. So there are Viagra in Australia has now come off PBS, so it's a lot cheaper, and this was very often offered to patients when the doctors were feeling maybe quite guilty that they couldn't improve erectile function, and they would say, well, look, we've got Viagra and we could give you this. Personally, I don't see that it's very effectual after a radical prostatectomy. There needs to be some erectile function. So I've been talking to the medical staff that I work with and saying, I don't see any benefit in offering the Viagra, because all it does is create disappointment for the men when they're not getting an erection, and they'll often stop there and not want to progress for anything else because they're thinking this should work. I very clearly say to men, this will probably not work at all. You need to have probably a 5 out of 10 erection. I get the men to rate their erections, a 5 out of 10 erection for it to work. If men take it, they always tell me that they've had about 50 beers before they take it to relax. It doesn't work with alcohol, and it really needs to be taken after a light meal. So some men say, I have seen this work with men on hormone therapy. Some men or couples say, look, it takes the spontaneity out of sex having this. And in some ways, I think, yes, spontaneity can be taken out, but often, in any relationship, we probably know when we're going to have sex, which is when the kids are out, or when there's, when you're not so tired, and it's often not as spontaneous as we like to pretend that it is. But I have suggested to some of the men that maybe they give that responsibility over to their partner, and there might be something that indicates to them that they might need to take their Viagra for that night. It could be a meal, a trigger meal, and I suggested that maybe, on the night that soup is served, or or someone says, I feel like soup tonight, or whatever, that's the actual key to go and take the tablet. One of the urologists said to me he'd probably be having soup every night if that was the case. But it makes some eroticism around the actual taking of the tablet, and brings back some fun and takes a little bit of that lack of spontaneity out of there. It doesn't work it's not good if people have a cardiac problem. And one of the issues I find with it is that no one likes to take tablets. We can very rarely take a full course of antibiotics. So it's difficult for people to continue taking medication. It was also a Viagra tablet is about $3. We also have Cialis as well, but 4 of those tablets, 10 milligram tablets, work out to be about $60 to $80. Some people can't afford that sort of treatment. So often the Viagra, I would see it more successful in hormone therapy. Then we have the vacuum devices, which they range from $50 up to $600. Some health insurances will cover the vacuum device, and so they can get it through their health benefits. There are lots of different lassos or rings to put around the penis, and it cannot go around just the base of the penis, or it can go around the scrotum and the penis. The big problem with the vacuum device is that they have a hinge effect, so the actual root of the penis isn't filled with blood, so it actually isn't as stable, and it needs to be guided in for penetration. Some men use the vacuum device purely to bring back some length after they've had a radical prostatectomy, but I also suggest to men that they can masturbate or stretch their penis in the shower, and that will bring back some length to the penis. If they're using it for that, I don't encourage them to use the ring. They also need to use, sometimes it's important to trim up the pubic hair because that can get caught in there and can cause a lot of pain, but it's, and the ring can only stay on for half an hour. And I have had some men, I'm a farm girl, so we put ring on sheep for them to lose their tail or their testicles. So I would be very paranoid about using this myself, but one man said that he put it on and his wife had a timer on her watch, and she was going, we've got 24 minutes left, we've got 22 minutes left, we've got 20 minutes. He said, I couldn't take it, I had to pull it off because she was worried that she was going to find a penis in the bed, not attached to him. And some couples don't like the feel of the penis because it can be quite cool. It brings more venous blood in, not arterial blood, so it's cool to touch. So sometimes it's suggested that you can use warmed up lubricants to help with that. But for some couples it's not successful. For others, they really embrace this. So it's offering this and discussing this. And sometimes people will come back to me in the SWAT clinic to individually talk about this and problem solve how to use it. We look at different types of sex toys, and certainly there's a lot of education around lubrication. There is the penile sleeve, which can be put on with a belt, and certainly Richard Wassasug from here has done some research on that and seems to be quite successful. With the vibrator that looks like a microphone there are different rumbles with the vibrator. So the smaller ones can be quite high pitched, and the one that looks like the microphone there is called a wand, and that has a deeper rumbling. It's far better for women who are postmenopausal, and it's far better for men who, if they actually touch their penis with that low rumbling is much more pleasurable to them than the high-pitched, smaller vibrators. So we talk about that and talk about incorporating that into their sexual practices. Some men or couples are quite embarrassed to be going to a sex shop, so I've offered to meet them at our local sex shop and take them in there so that they don't feel as uncomfortable. A lot of people are using online services now, and the great thing about that is when they use their credit card, it will say, in Ballarat, it will say Ballarat Books instead of sex shop, and it comes wrapped up in something very nondescript, so it doesn't indicate that you've got some fluffy handcuffs from the local sex shop. So it actually allays some of the fears. And so even to discuss that, I hadn't been into the sex shop in Ballarat, and that was part of the course that I was doing through De Souza. And so my mother lives a couple of hours away in a place called Hamilton, and she'd come to Ballarat to get her sleep apnea machine downloaded. She's about 5 foot, tiny little thing, and we'd gone around and got her sleep apnea machine downloaded, and then she was in the car with me, and I said, look, Mum, I've just got to go to the sex shop. I've got to see what their bestseller is and report that back in the course. And, you know, next minute I turned around, she's got the seatbelt off, she's got a handbag, she's whipped into the store with me, and she's 83, and she said it was just amazing to see that. And that was the first time she'd ever been in a sex shop, and it was my first time. So the first time I'd been in one was with my mother. And there was some tingling cream. My father's had a stroke, so he can't speak, but he still understands everything. My mum put the tingling nipple cream on her lips before she left, went back to my house where my dad was, and she gave him a kiss, and she said, "Can you feel that?" And he said, "Yes." And she said, "Well, that's tingling nipple cream." And he went, "Oh!" And, you know, just the fun for them for just a second was lovely to see it as well. But talking about, you know, how to implement sex toys in, and I also find we assume that people aren't using this. I've found that a lot more people are using sex toys than I thought were being used, and certainly all age groups are using them. I often discuss lubrication, how important it is for people to understand about that. Certainly for women in the group, about the fact that after they've had menopause, it reduces their vaginal lubrication. There is thinning of their vaginal wall and urinary tract, so they're more likely to have pain, UTIs, or bleeding after sex. So I also talk about the difference between a vaginal hydration, which their gynaecologist may have ordered for them, which is actually they'll use this a couple of times a week just to create some thickening of their vaginal wall and to nourish the vagina. That's different to lubrication that they would be using for sex. I also talk about that sometimes, you know, it's men see that when women are well lubricated, that's an indication that they're keen or they're very involved in the sexual experience. So you can't use that as a guide now, because with after menopause there will be that reduction. So you need other ways to report that to one another. And the same with the men that can't get an erection. It's very easy for us girls to see, or gaming to see if the partner's keen on sex, because there is that visual erection. But now after prostate treatments, those things aren't the same. So you have to find ways to actually indicate that you're involved and keen in the sexual experience. And sometimes that's about feeling your pulse rate. Is that going up? Or some men report engorgement of their lower abdomen. And so I talk about being a bit more mindful about what's actually making you feel like you're aroused or involved in the sexual experience. We also talk about the different types of lubrication, silicone, I have those there, so we pass it around, and that's very soft and slippery. The water-based, which a lot of people use the water-based, but I remind them that that can be reabsorbed very quickly, so that you may need to use that more than once. A hybrid of both the water and silicone is very, very successful. And then there's natural lubrications, and some people now tend to be using a lot of coconut oil, and some people like to do that. The silicone one feels less tacky. However, they need to be mindful of when they're using that with sex toys. So that's a discussion that has, and it's women will be very, very engaged in this and say, see, I told you I was involved in it. It's just that, there's a reason I can't get, indicate that I'm lubricated anymore. And I think it's important to be addressing both issues in the workshop that we spend together. Then we look at the intracavernosal injections. Men will get an order for this from their doctor, and they can come and see me, and I will teach them the first dose. I think here, often the doctor will give the first dose, from what I've heard in some of the hospitals around here in Vancouver and also in Calgary. So the doctors will talk about it. I will educate the men and their partners about they can use it 3 times a week, where to inject, how to inject. They will ring me back. I usually give a smaller dose, or encourage them to give a smaller dose. I don't give it. I show them how, and they give it to themselves. It is an interesting clinic, because they'll come in, they'll have the injection, and then we sit and wait, and then they take down their pants again, and we both look and go, "Ooh, yes, there has been some rise." And we are expecting. I'm expecting more than just some tumescence, just some thickening of the penis. And recently, I had an 86-year-old man come in who has a little bit of dementia, and he wanted to have erections, and so he had a small dose of the Cavaject we were using, and he successfully injected himself. And I asked him to self-rate his erection, and he said, "Look, I think it's about a 5 out of 10." And with that, his wife was sitting, his 84-year-old wife was sitting next to him, and he turned around to her, and she just reached out and said, "Yeah, no, I think that's a 5 out of 10 erection." And I thought, oh, look, I just love, they were very matter of fact. There was no embarrassment or anything. It was just, here she was at 84 reaching out. I thought, gee, I'd love to have her in my clinic every day just testing the men and their erections. But I walked out and thought, I love this job because it just brought so much joy to them. And he did say, "Look, I orgasm about once a week, but I'm exhausted after it." He said it takes a whole week for me to recover. But they talked about how important it was to have connection, and she liked him to rub his hands all over her body once a day, and he liked to have an erection and penetrative sex once a week. So that's what they did, and I was able to facilitate this. And, it's certainly... I was thinking, oh, gee, he's got dementia, and will this be a problem? And then I thought, it's not really my place to probably worry about that. She was there and she was educated as well, and he was able to perform this, and he was referred to me by the doctor, and it was very successful. He rang back and said, "Thank you very much. It's been fantastic. We're really happy with this again, and I was very good at my injection." So, I've certainly encouraged the injection for men after radical prostatectomy, because it's the one thing that does give them success. And what I find is the men will walk in naturally very embarrassed about the fact that they're going to have an injection, and I'm going to be there observing that. And so they walk in a little bit nervous and a bit sullen with their head down and that. But after the injection, there's a little bit of a strut as they walk out of the room. Even if it's a 3 out of 10 erection, they will say, "I haven't seen that for a long time." And one man recently said to me, "Intellectually, I don't want to say that that's actually had an impact on me." But he said, "All I want to do is go, hallelujah, I've finally got an erection again." And he rang me or messaged me an hour later, and he said, "Gentlemen never tell, but I'm not a gentleman," and it was fantastic, he said. So, and he had been very prepared for him not to have a penetrative relationship or sexual relationship after his surgery, but he found that he had all these feelings still, and so he wanted to pursue this. So there are numerous reasons why people want to have the injection, whether it's for masturbation, whether it's for self-image, whether it's for the fact that they're on their own and they want to know that they can have an erection if they go into another relationship. I would find that the people that I spend a lot of time with are the man that has got prostate cancer that's been recently separated in that early 50s that's looking to repartner again, and they'll often role play with me how they're going to talk to women if they meet them and about their erectile dysfunction and how they'll manage that. But they will report to me that they feel better equipped when they know that at least they've got an avenue to get an erection if they want to. There is also the opportunity for men to have penile prosthesis, and this is offered in Ballarat. So the chairman of Prostate Cancer Foundation, he developed prostate cancer at 50 and had a penile prosthesis put in, and he's now 70, and he said at 68 he went and got a second one put in, and he said he likes to think that he wore the first one out. It's been very successful, but the second time around there was a lot of scar tissue, so it was dependent on his wife to actually accelerate or to turn on the pump. And so, but he said it was very successful for him, and usually they'll last about 10 to 12 years. There may be some replacement of parts needed, but after that first couple of months, if there are no infections, they're usually in and they're very, very successful. In Australia at the moment, there is some a new surgery where they're taking the sural nerve out of the leg, and it does leave the leg numb, and they're doing a sural nerve transplant. I think there's been about 16 people that have had this done, and it's by plastic surgeons that are doing the test, they're doing the surgery. One of my patients has gone and had this surgery done. It takes 6 months before they'll know if this is successful, so I'm waiting for him to report back. He's about the 3-month mark now. So this is a new exploratory surgery, and it's not just with prostate cancer patients, it's also with spinal injuries and diabetics, and I'm sure at this point they're picking very successful candidates, but it'll be interesting to see where that research heads. So we also look at some of the myths that are around about, you know, older people don't have sex, and I was recently on a ward round and there was a 24-year-old intern talking, and this man was talking about wanting to have sex, and he was 52, and the intern said, you know, as we were walking away, said, "Oh my God, is he still having sex at 52?" And all the urologists pounced on him because they're all over 50. He said, "Of course, would you like to think that you're not having sex?" But for him, he thought 52 was very old. But I think, you know, there's a bit of ageism with that, and certainly this 86-year-old couple were very happy to have sex. I have one patient who, him and his partner have sex 3 times a day, and they're close to their 80s, and it's what they do. So we discuss that. We talk about the orgasm without an erection, about communication isn't affected by lack of intimacy, that sex is finished when erectile dysfunction occurs, and there is discussion about this. There is a lot of talk out there that I find that comes back from the community and from the men, is that they're worried that their partner will catch cancer from them having sex. So, and that's out there a lot more than I thought it would be. And then the other one is, if you love someone, you'll get an erection. And some women have reported to me, if my partner really loves me, he would get an erection. And some men, you know, say, is it that I don't love my partner anymore that I'm not getting an erection? And so often, you know, these sort of myths generate a lot of discussion. So we, and some people just haven't thought about these things as well. But this is a good group discussion, and I think by the time we've gone through everything, I used to put this at the start, but I find putting it closer to the end of the session is better, because people are more happy to discuss things. And I talk about the thoughts that men report to me, that they feel like a failure, that one of the biggest ones is that their partner will leave them, that they're no longer functioning as a productive and healthy partner, and that really they need to go and find someone else because I'm no longer a functioning male. And that, I would have to say, is probably about 90% of the men, anecdotally, that I see will discuss that. There is a lot of men report feeling depressed, and they wonder if this is normal. So I try and normalise these feelings very early on, and, you know, so discuss it before they have treatment, discuss it during treatment, discuss it after treatment. And sometimes they take this on board, sometimes until it's an issue for them, they're not really thinking about it, but really reinforcing that this is normal, these feelings are normal after having an impact on their sexual well-being. And the other thing is, another thing that men report is that they feel guilty for thinking about sex, that actually after the surgery they've found their PSA is normal, they've recovered from the surgery, their continence is recovered, but they're really focused on their erectile dysfunction. And they say, I feel really bad that I'm focusing on this. And I say to them, if you weren't eating, you weren't sleeping, you were not using your bowels, we would find some way to deal with this. This is just another element of the side effect of your surgery that we are looking to help and improve for you. So don't feel guilty about it. We want to bring you back as much as we can to your pre-cancer state, and certainly make sure that you have an excellent quality of life. So I give them some homework, which is a sensate activity, which is about them actually having going home and having some non-genital touching, 30 minutes each or whatever they decide. So no touching of the genitals, but just reporting to one another where they like to be touched, and bringing that intimacy back into the relationship if it's missing. For some it's not, but for some it is. There is setting some quarantine time for this activity and proceeding at their own pace. They might do this once a week, once a month, several times, and then they may proceed on to genital touching. It just depends on how comfortable they are with this. But I give them a handout that actually steps them through this process. So that brings me to the end of the what I do, presentation I do for the partners in the When Cancer Joins You in the Bedroom, and I just leave this slide up there at the end. And at this point, people may hang around and talk, go and have a coffee. Some people just get up and go. Some people ask, can they book into the SWAT clinic with me? It's just dependent on the individuals, and it seems to be having signs up and giving credence to sexuality. There's been more discussion in the Cancer Centre. I'm presenting this and discussing this with the radiation oncologists, the medical oncologists, the staff. It's advertised in the wellness centre. So people are realising that it is okay to discuss this, and it's probably giving permission. So they talk about the fact that the clinic or the session that they go to is the first time that they've really had their needs addressed. It's been, the medical staff are feeling happy that they can actually address this issue, and they're more than happy to refer on to me. I would say that not a lot of prostate cancer nurses, all of them are happy to do this, but there are some of it. So where to from now? I'm trying to benchmark in other organisations, and that's part of the reason I've come over here to Canada. Validate the program through research. So I'm looking for funding and about to do some research on how what impact this has had on men's and quality of life and their partners, and really to get feedback on, is there anything else I could include? Is it long enough? Is it too long? What else I'd like included? What would they like taken out? And if this is successful, my future plan would be to roll this out as a education to with all the resources to the other prostate cancer nurses in Australia, and use this if they're not feeling comfortable. They have all the supports there with the script, and certainly the PowerPoint, and with resources as well. So thank you to all of you for listening. Certainly you can contact me via email at any stage, or if you've got some great thoughts or you want to give me some comments on this, I'm more than happy to hear that. And so, now I'm going off to see some of my very close friends from Australia that are over in the United States and Canada, just a couple of my really good friends. And so thank you very much. And I love Canada. I absolutely love Canada. So thank you.